My honor, my privilege to basically kick off the next section of this meeting as we kind of honor a luminary in the field of radiation oncology. The International Prostate Cancer Update is one of the longest running and most successful annual scientific meetings dedicated to the discussion of prostate cancer and research. We come from all over the world, we come together, and I think we do a really nice job of making sure that each of us know what's happening in other ends of the earth, if you will. Over the last 3 years, the IPSU has enjoyed the involvement and support of physicians and researchers working in pharmaceuticals, industry, and dedicating to make a difference in men's lives to try to improve outcomes. As I say all the time, like it or not, we all become patients, and whatever we can do to make that patient experience is not only for the others, but ourselves as well. To honor these important contributions to the field of prostate cancer research, in 2024, the IPCU sponsored Grand Rounds in Urology, and the IPCU founder and program director emeritus, David Crawford, established the Brian J. Moran Distinguished Lectureships Award to recognize outstanding individuals in radiation oncology that have and continue to embody Brian's dedication to scientific and research for improving patients' outcomes through his life work and consistently supporting the IPCU conference as well. The mission is to shape the future direction of the diagnosis and treatment of prostate cancer. Brian Moran was a personal friend, and he was one of the brightest minds in the fight against prostate cancer. Medical contributions have really are going to establish his legacy. They're going to outlive him, unfortunately, as he passed away this past October. But he's affected so many generations of individuals that his legacy will continue to go on and on and on. Brian really did dedicate his life to the field of radiation oncology, the advanced prostate cancer brachytherapy, not only in the science, but also in the utilization and the acceptance. It really is remarkable what he was able to do, but unfortunately he himself lost his life to metastatic bladder cancer on October 13th, 2024. He's greatly missed, but through the generous sponsorship of Theragenics and his Prostate Cancer Foundation of Chicago, his name and his legacy will live on. I'm very honored today that we have Dr. Brian Davis, professor from Mayo Clinic and Radiation Oncology, to bring some words to this and to Brian and to provide a lecture in his honor. Dr. Davis did his Bachelor's of Science degree in nuclear engineering, so we got a pretty smart guy here. And then he decided to go to MIT and get an MS and a PhD in mechanical engineering. Then he decided, well, what the hell, I'll go back to medical school and do that as well. And did his residency at MSK. I've known Brian, for almost 2 decades now. He was a former president of the American Brachytherapy Society. He sort of helped guide my way, and I'm very, very indebted to a lot of things that he's done for myself. And it's my honor, Brian, to come up and give our lecture. Thank you.
Peter, thank you very much for that gracious introduction. I'd also like to thank Theragenics and the American Brachytherapy Society for sponsoring this important lecture. I'll have some words about Brian as well, but towards the end of the talk. So, really, Brian Moran, an unmatched legacy of permanent prostate brachytherapy. And I can tell you what I decided to talk about as part of this lecture, the major part of this lecture is right as COVID was starting, we were at a meeting with the American Brachytherapy Society at Big Sky in Montana, and our debate was focal brachytherapy versus why we treat the whole gland. And I was asked to advocate on part of whole gland treatment. And I know we're going to have some focal therapy talks, but I think it's also worthwhile to revisit some of the arguments why we treat the whole glands and what the limitations of focal therapy are. And also, having said that, I will tell you that we do focal therapy at our clinic, but we may use it for select indications that aren't necessarily what a lot of others are using. Here are my disclosures. And once again, Brian in memoriam. There's Brian on the left. In the center, there's his family, 4 children and grandchildren, his lovely wife, Betsy. And then there's a picture of what Brian did a lot of, which was brachytherapy. He was a mentor. I can remember I interviewed in his practice in the early 2000s, and I remember driving there to watch him do a seed implant case, and I said, I bet they're playing great music in the OR, and sure enough, they were. Here's some of the background of Brian. He was a graduate of Hinsdale High School in Illinois. He went to Loyola Medicine Radiation Oncology residency, also at Loyola. He was really the principal of the Chicago Prostate Cancer Center, very busy practice, and he treated over 20,000 patients with permanent prostate brachytherapy. I don't know anyone else that's treated that many, and I would say I don't know any urologists that have done more than 20,000 robotic prostatectomies, so very prolific, very busy. Here's a list of some noteworthy publications. I just want to point out a couple of these. He was very much an innovator. He published, you see the third one down, he published on the use of cesium, which is still is a newer isotope, and that's to his credit. And then also the last one, after our debate in 2020, he published on focal LDR prostate brachytherapy, single institution. So he was, in addition to prolific implanter, he was very much an innovator. And here is actually the initial slide on this Brachy Summit, Whole-gland versus focal therapy, and I put in there update 2025. It was Brian and I, as good friends, both Brian and Jay, talking about the yin and yang, the pros and cons, and why I treat the entire prostate as the standard, because localized prostate cancer is generally multifocal. And very importantly, imaging fails to localize all prostate cancer. Focal therapy results generally are inferior to whole gland treatments in outcome. Focal therapy does not appear to reduce toxicity, and I have to disabuse patients of that notion. Guidelines, to my knowledge, still do not continue to support its routine use as compared to whole gland treatment, meaning surgery, brachytherapy, or external beam. But I'll also acknowledge when we use focal therapy on protocol, and our urologists are very good about that, many different technologies. And then for salvage treatments, sometimes, for example, if there's seminal vesicle recurrence after prostatectomy and we've already given radiation, it may lend itself readily to focal therapy. And in this regard, I do present one case where we have a 56-year-old presents with Gleason 3+4, PSA 4.4, 2015, gets external beam treatment with the older conventional fractionation regimens, and then PSA rises to 11.9 4 years later. This was done elsewhere. A choline PET scan reveals apparent prostate recurrence in S1 osseous met. Prostate biopsy is positive. Gets SBRT to S1 and cryoablation of the prostate and short-term ADT. This was done at our institution. The ADT is discontinued. The PSA rises to 1.4 by late 2020, and PET reveals local nodal recurrence only. We do androgen deprivation and salvage nodal RT at our institution. ADT was discontinued. PSA rises again, not an uncommon story, but it's found that the SV is the only site of recurrence in early 2022. And my colleague, David Woodrum, interventional radiologist, along with one of my longtime colleagues, Lance Minders, is engaged in this practice. They have a cryotherapy unit that is functional in an MR for over a dozen years. And without androgen deprivation therapy, the patient is treated in early 2000, in mid 2024. PSA declines by a factor of 10 to 0.32. Testosterone is normal. PET PSMA shows no area of recurrence. So I consider this a kind of niche success for focal therapy. And this technology, maybe it isn't always used what was originally intended, but we sure use it in these select cases. But now also talking about Brian's experience that he published with focal brachytherapy. This was published in 2023, several years after our debate. 132 patients treated over 12 years, most of them with cesium or iodine 125. And his conclusion is focal LDR prostate brachytherapy may offer a more conservative therapeutic option for localized prostate cancer in select patients. And I know Dr. Rossi is going to discuss this more in his upcoming talk. So what talking about some of these points, prostate cancer is multifocal prostate cancer, biologic, prognostic, and therapeutic implications, a very important paper. And in this paper, they found that 50 to 83% of prostate cancer is multifocal, at least 40% of the time it's bilateral. In so-called, that's in, quotes, clinically insignificant cancer. And I think this is maybe the argument that's used by those who advocate for focal therapy. We're only treating significant cancer, where you can still miss a small cancer that's Gleason 9 that's lurking in the prostate, and you don't know it's there, and it goes untreated. Clinically insignificant cancer that's less than half cc. One study found that 69% were multifocal and 37% were bilateral. This comes from a study that we published. I'm a co-author on it from 2000. I think this is well known, but it's worth reiterating that essentially prostate cancer in a vast, not insignificant number of cases actually touches the urethra. And if you're doing cryotherapy, particularly whole-gland cryotherapy, ablative therapy, you're going to miss cancer. And with these results in this study that was over 350 right at 350 whole-mount prostatectomy specimens processed by David Bostwick. And these were really not too advanced cases. Only 7% were T3, so 93% are organ confined, and over 80% had PSAs less than 20, and biopsy Gleason score only 9.5% were Gleason 8 to 10. So this is your typical cohort of those patients that are early low risk and intermediate risk patients. And what was found is really 17% of patients had cancer touching the urethra, and 84% of patients had cancer within 5 millimeters of the urethra. So the advantage of radiation or brachytherapy in that regard is that radiation is much more harmful to cancer cells than it is to normal tissue. And I tell patients this all the time, that cancer cells are much more sensitive to the harmful effects of radiation compared to normal tissue. That's why we can radiate a volume of tissue and keep the normal tissue and function intact, normal anatomy and function intact, and eradicate microscopic cancer cells. So with radiation approaches, we can radiate the urethra, but if you're doing an ablative approach, you're going to damage the urethra because it's indiscriminate with respect to treating normal and cancer cells. So the conclusion of this study, which when it was published 25 years ago, kind of made a splash, and a couple of other centers published similar studies, that urethral sparing in minimally invasive therapies may not treat all cancer. In radiotherapeutic management, this is less of an issue. Also, prostate cancer imaging is imperfect. Here's one study that, looking at 83 tumor foci, were identified in 26 patients. 31% of the total were visible on multiparametric magnetic resonance imaging. That is a low amount, approximately 1/3. And also for tumor foci containing Gleason pattern 4, 0.5 centimeter or greater multiparametric magnetic resonance imaging only detected 77%. So it's over 20% went undetected. And this is a study that, as radiation oncologists, we all love, and this is the 10-year results of the PROTECT trial, where the radiotherapy group and the surgery group essentially show that very few developed metastases. For example, in the group that was left untreated, that underwent active surveillance, where up to 40% of patients within 5 years did get active treatment, 6.3% developed metastatic disease, whereas with localized treatment, surgery or radiation, was 2.4 to 3%. And then I would argue that you may have similar results when you're doing focal therapy. You're leaving untreated cancer, but essentially untreated prostate cancer progresses, and focal therapy results resemble active surveillance, not whole gland treatment. And what do guidelines state about focal therapy? The NCCN, whole gland treatment or active surveillance in selective patients, but focal therapy is not endorsed as a primary state-of-the-art treatment. Furthermore, what do guidelines state about focal therapy? AUA, ASTRO, SUO, similar type of things. And here we have, no evidence of clinical principle or expert opinion, looking at low risk, intermediate, and high risk, and focal ablative therapy. right here, but this is really this is where this was categorized by AUA, Astro, and SUO at that time in 2018. Also, EAU, Estro, focal therapy remains experimental, while cryosurgery and HIFU are still lacking in long-term convincing results. Here's hot off the press, the updated NCCN guidelines from early 2025, and once again, it's the same thing. It is surgery or radiation. And now, looking at this, also in some of the subtext, principles of local secondary therapy post-radiation, there's no consensus as to the most appropriate radiation volume, and there are published experiences for both focal, partial, whole gland reirradiation. The panel recommends that patients receiving local therapy for RT recurrence are treated within the context of clinical trials when available and/or experienced centers. So this is not one where we have a standard recommendation for focal therapy after those few cases where we have recurrence after radiation. I'd also like to talk about, in one slide here, our experience using permanent seed implant with just under 1,000 patients. And this graph on the left is what we found was a 2.1% local failure rate at 10 years. And when you look at it with the competing risk of death, that goes up above 40% over 10 years when you're treating an older population. This is consistent with what others have said earlier in the area, that whole gland treatment, for example, with permanent seed implant, which I strongly advocate when patients certainly want to avoid therapy and they're younger, and they ask me what would I choose, I say 1A is seed implant, and 1B would be SBRT. So rationale for whole gland treatment with focal therapy as a backup. Prostate cancer is most commonly multifocal. Once again, reiterating these, all foci of prostate cancer are not imaged. Excellent long-term results of whole gland prostate cancer treatments support this approach. All major guidelines support whole gland treatment, but focal ablative treatments for select limited stage in many salvage cases has evolved to be a useful tool. So that's the first part of the lecture. The second part of the lecture, I'm going to switch gears here, and I know that this is a very hot topic at this conference and something that we've been involved in quite a bit at our institution. In 2010, the FDA told hospitals and cancer centers, you just can't continue to do PET scans if your IRB approves it with specific agents. And we were doing C11 choline at that time. We have our own cyclotrons. C11 has a carbon-11 has a half-life of 20 minutes, so if you're going to do that, you really do need a cyclotron on site. And then the FDA said, no, you have to apply for a separate application to get it approved at your institution. And we did that. It was a very lengthy application process. They wanted a $1.8 million application fee, and then with that, you can put in a letter asking them to waive the fee. And a number of months later, they approved it and waived the fee, but also said your application for PET choline is not something where other institutions can piggyback off it. So over the last 15 years, we've done over 15,000 choline PET scans, and of course, we've shifted mostly to PSMA for upfront management with patients. But we still use PET choline because we do find there are occasional patients where the PSMA is negative and the PET choline is positive. This is picture of the Mayo Clinic during our 6 weeks of summer. It's a staged photograph. Those geese that you see up there are stuffed, so just to make the photo look nice. This is a study from one of my colleagues, Jeff Carnes, a surgeon who does salvage lymphadenectomies, along with an Italian surgeon, Alberto Brigante from Milan. They combined data and published this over a dozen years ago, looking at after radical prostatectomy, if patients are found to be pathologically node positive, if they received adjuvant hormonal therapy alone versus adjuvant hormonal therapy plus radiation, patients tended to do better with adjuvant hormonal therapy and radiation. Now, this is a retrospective study, so there's some inherent biases, but basically the cancer-specific survival from the pre-PET era with the combined therapy was 86%, whereas with hormonal therapy alone it was only 70%. And I know Jason Astathiou is going to elaborate on this further in his talk this afternoon. But this provides a basis for why we strongly favor with lymph node recurrence to treat patients with combined hormonal therapy of various durations and radiation. So what our favorite approaches for salvage of nodal recurrence after primary therapy, surgery, radiation, or both, is to treat the nodal groups comprehensively, not just PET avid sites with SBRT. I'm very intrigued by the data that was shown with the copper-64 bivalent PSMA ligand, that it appears much more sensitive and also reveals greater nodal involvement. And although I'm not showing this data, my colleague Jeff Carnes has published data that if he would see 1 or 2 lymph nodes positive on PET choline and then do salvage lymphadenectomy, on average he would find 4 or 5 lymph nodes, and a lot of times they would be bilateral, as opposed to on the PET scan they would only be unilateral. There's retrospective data also from Belgium showing that you have a higher recurrence rate if you're just doing SBRT versus comprehensive nodal evaluation, but we're still looking at clinical trials to answer these questions, but that's been my bias from the get-go. And then we also want to combine it with at least some androgen deprivation therapy. The duration is up to debate and tolerance of the patient, but the synergistic effect of radiation, at least some androgen deprivation therapy. And then we transition to intermittent ADT with PET scans for relapse, and might end up treating patients again. And we've had a number of patients, which I'm sure everyone in this audience who treats a lot of prostate cancer can see, of cures of patients, at least that's what they appear, that have had lymph node involvement, both pelvic and periaortic lymph node involvement. This is just to reiterate some of this, this is an invited review article from 2017 that we published, and we were asked to evaluate prostate-specific PET agents. And at that time, it was choline, PSMA, which was still not available uniformly. We did have FDA approval to do a PSMA in certain limited studies, and also fluciclovine. You see that in red is the PSMA, which had the greatest sensitivity based on PSA level less than 1, 1 to 2, or greater than 2. But you see those higher orange bars in the choline. Those actually were studies at our institution where we used essentially higher concentrations of choline than a lot of other centers. So it actually approaches the sensitivity of PSMA, but from my experience, it's not quite as sensitive, although with some of the PSMA agents, you can get false positive bone mets, particularly rib mets, that you don't see with choline. So we still use it in some cases, but PSMA generally up front. This is a study that we did. We've really in our choline experience, we emphasized biopsy when we could, just to rule out other causes of PET avidity, and to make our results more robust. And we published this study looking at if PET choline appeared positive in a certain area and we biopsied, what was the chance of us getting a positive biopsy? So not surprisingly, the deep pelvic lymph nodes was greater than 90% positive biopsy rate. Periaortic was 70%. And in the inguinal area, particularly if you have bright uptake and it's unilateral, we got 33% positive biopsies. The easy thing about it is the inguinal lymph nodes tend to be easy to biopsy. So if there's and this is important for designing radiation treatment fields, if you want to make them go out to the inguinal regions, we can do that quite readily, but it's nice when you can to verify that with a biopsy. And this study, I'll go through this, is something that we presented at Astro about 7 years ago as an oral presentation. Our question was this: if you have patients that undergo prostatectomy, then salvage radiation, and they have a rising PSA, and they find that their C11 choline is positive, the question is, where is it positive? And what we did is we found 41 patients that met that criteria, and we had histologic confirmation in approximately half. So, and then the other half we judged by treatment response, which, when you look at a lot of these studies, they don't even mention whether they've done much in the way of histologic confirmation. So I think that this data was very robust. This shows the map of where we saw the recurrences, and this is, by the way, where we did all of the biopsies. And this is a greater breakdown. One thing that we looked at is, did we see recurrences in the prostatic fossa where we had given radiation? Yeah, we saw about 2% recurrences. So this was judged to be that the radiation was very effective. These are, was it on the edge? And then the rest of these were outside of the radiation treatment field. And up to 83% have lymph node only failure. And this is markedly different from the old days when we didn't have PET scans and the PSA would be 20 or even up to 50, and we were imaging with CT scan and bone scan, and at least half the time we'd find a positive bone met. So the story is, with PET scans, we find lymph node only recurrence, which are much more salvageable and even curable. So these are the locations of those. And so the conclusions of this study is that C11 choline PET's useful imaging modality, which is, this of course applies to PSMA. In-field sites of recurrence were uncommon, 4%, and the majority of recurrences were out of field. They were nodal and would be encompassed by pelvic RT fields. L5 S1 interface, or the aortic bifurcation, is something that we advocate including, whereas older guidelines would not include those regions. So how do you deliver nodal evaluation? Nodal irradiation when you have select recurrences? So what this shows is this is where the patient was previously radiated. This is where PET scan shows that they're positive, and how would you go about doing this? And this is essentially how we were doing. We'll get simultaneous integrated boost, maybe at different levels, and this is in 25 fractions, and this is conventional elective nodal radiation. This differs from those that would do SBRT to this site and this site, and say you have a recurrence later here, it becomes a little more difficult to radiate, and we would give this typically with 12 to 18 months of hormonal therapy. And here's a little more detail of where we saw these recurrences. So 9% would even go up to this high. And we've been radiating periaortic lymph nodes using IMRT for over a dozen years. We published also on adverse events afterwards, and you do see some temporary GI adverse events, but just grade 1, some increased bowel frequency and maybe use of antidiarrheal medications. And interestingly, we also see some increase in the GU adverse events, but really within the scope of the error bars. So this led to a clinical trial, which we've completed, and we're submitting this in the next several weeks as an abstract. And really the hypotheses were that, new prostate cancer PET tracers can identify sites of recurrence in patients at an early oligometastatic stage, predominantly a nodal relapse only, following adjuvant or salvage post-RP or primary radiotherapy. Treatment of such patients with androgen deprivation and contemporary IMRT or IMPT techniques with IGRT, that's intensity modulated proton therapy with an image-guided radiation therapy, is associated with low rates of toxicity. Radiation of pelvic plus or minus periodic nodes leads to low rates of in-field relapse, and moderate hyperfractionation, this is the key to it, will have little or no difference in toxicity compared to conventional fractionation. And this is the clinical trial that we started in 2020, and PI, it's basically 2-to-1 randomization where we do this in 15 daily fractions, and this is a common fractionation regimen used in GI cancer such as pancreatic cancer versus conventional fractionation. We also did this with protons, where we made protons a stratification factor. Really, if you're radiating periaortic lymph nodes and you use posterior oblique fields with protons, you avoid a lot of bowel radiation. The bowel radiation is about 30 to 40% of what it is with IMRT, but even with IMRT alone, the side effects are low, but we still wanted to be able to offer that as part of the treatment. But it wasn't really a question comparing protons versus IMRT, but we recognize in terms of a toxicity study that can impact it, so we included that as a stratification factor. And active monitoring going out to 24 months and event monitoring out to 60 months. We opened this in January of 20. Our accrual goal was 84 with the goal of being able to analyze 78 patients. We accrued all of our patients by November of 23, and we found that 81 patients are eligible for analysis. So if this abstract gets accepted, we'll give you an update. But one of the primary endpoints was the 3-month toxicity, and I can share with you we found no difference between moderate hypofractionation and the conventional fractionation. So a year or two in this study, we all decided that off study, when patients didn't quite meet the criteria for this trial, well, we've been using this as our standard when we're doing salvage comprehensive nodal radiation, the 15 fractions. And circling back around to Brian Moran, just a great individual. This was from an Astro meeting. He rented a boat to cruise around the San Diego harbor. This is one of his coworkers with him. You know, I can say Brian passed away on October 13th, 2024. He was 82. You know, as a physician, radiation oncologist, mentor, and friend, he really didn't have a rival. He was very well liked, extremely well liked, and for good reason. He himself was also a cancer survivor in his 20s. He had a testicular cancer and received radiation. And that convinced him, his experience, that he wanted to become a radiation oncologist, and that's what he did. He received radiation and chemotherapy. You know, he was a very collaborative, gregarious, and entertaining individual. I mean, I could tell you stories, but it wouldn't be proper for this format. We shared patients back and forth between Minnesota and Illinois, and you know, we all miss him. Such a great individual, and this was well before his time. So once again, thank you to the organizers for allowing me to speak for this important lecture. Thanks also to the supporters of this talk. Thanks very much.